In the last video, we examined the purpose section of the policy on medication-facilitated airway management. Here are the fundamental takeaways from that section. Appreciate what success in advanced airway management truly means. Even though securing an advanced airway might be the initial objective, it is not the only favorable outcome. The patient may improve during the process of treating underlying conditions and stabilizing. For example, you encounter a patient with pulmonary edema, malignant hypertension, and renal failure. The patient is anxious with profoundly labored breathing, diaphoretic, in a high Fowler's position, with circumoral and peripheral cyanosis. And here are the vital signs. The patient receives nasal prongs at 15 liters per minute, a sublingual tablet, CPAP, vascular access, and after medical command, push-dose nitrates. Before long, the patient dramatically improves, shifting the original treatment pathway, which called for airway protection, due to a failure of oxygenation, ventilation, and her anticipated clinical course, to manageable medical supervision. Exemplary patient care is solid airway management. Treat all barriers to ensure the patient is physiologically amenable to intubation. Maintain the patient without inducing or exacerbating hypoxemia, hypotension, bradycardia, regardless of advanced airway placement, and the goals of MFAM are met. There will be incidents when adequate resuscitation is impossible. Since we are committed to performing airway management safely, if we cannot correct physiological barriers, we do not proceed with induction or intubation. 3 physiological obstacles could foil a plan to secure an airway using medication-facilitated airway management. We call these physiological barriers to safe airway management the HOP killers. HOP stands for hemodynamics, oxygenation, and pH. A patient is considered hemodynamically unstable when they present with a shock index greater than 0.8 or a systolic blood pressure less than 90 or a heart rate greater than or equal to 130 or a suspected metabolic acidosis. Any patient meeting the aforementioned vital sign metrics is considered unstable and commands Q2 to 3 minute vital signs, continuous crystalloid boluses and fluid delivery as needed, recurrent administration of push-dose pressors, along with the use of the unstable medication dosing regimen. There is one exception to utilizing vasopressor support, and that's in trauma patients where permissive hypotension is encouraged and crystalloid bolusing is discouraged due to hemodilution. Keep the patient warm, oxygenate, administer TXA, and transport rapidly to the trauma center. Hypoxemia is poorly tolerated. A transient desaturation in a patient with an evolving stroke could increase morbidity and mortality by over 50%. When you add obesity, anatomical challenges, critical underlying illness, and comorbidities into the mix of factors affecting oxygenation and oxygen consumption, it is unmistakable how vigilant pre-oxygenation is a significant factor in safe, advanced airway management practices. Patient is considered inadequately oxygenated and therefore unlikely to tolerate an intubation attempt without critical desaturation when the pre-intubation SpO2 is less than 93%. However, when the pulse oximeter reads 93%, the real saturation is considerably lower due to pulse ox lag. The pulse oximeter reading is at least 30 to 45 seconds behind the actual number at any point in time. What can be done to improve oxygenation? Elevate the head of the bed or patient torso at least 20 to 30 degrees. Early in the patient contact, initiate a standard nasal cannula at 15 to 25 liters. Utilize a tight-fitting oxygen mask. Reposition the airway. Use airway adjuncts. Try CPAP. And perform a modified jaw thrust in altered patients. Initiate low rate, low volume, low pressure mask ventilation, preferably with 2 providers. One important note, don't use a CO2 cannula to administer no DSAT because it doesn't work to oxygenate. The microstream nasal prongs detect breath rate and CO2. It will not produce the desired nitrogen washout from the tracheobronchial tree. Intubating a patient with metabolic acidosis is one of the most difficult and challenging medication-facilitated intubations to perform. Why is a patient with a metabolic acidosis so dangerous to intubate? The patient will require resuscitation of pH, hemodynamics, and oxygenation. Fluids, pressors, and oxygen isn't all that's needed. Take a look at this patient's breathing. Do you recognize the rapid and deep respiratory pattern? It's Kussmaul's respirations. Here's the rest of his vital signs, including the end-tidal CO2. What numbers appear especially worrisome? All of his signs are troubling, but an end-tidal CO2 of 9 in a living patient with Kussmaul's respirations is a distinct indicator of a metabolic acidosis. The patient's rapid and deep spontaneous respiratory rate and compensatory respiratory alkalosis are keeping him alive. An attempt at MFAM will eliminate spontaneous respirations. When ventilatory effort slows, the patient cannot maintain homeostasis for long, and the pH quickly becomes incompatible with life. If MFAM is performed, the initial minimum ventilation rate is 30, with a goal rate fast enough to maintain the pre-intubation end-tidal CO2. To be clear, in this patient, the end-tidal CO2 at the receiving facility must be 9. Trying to properly manage the respiratory effort in a critically ill patient with metabolic acidosis without a ventilator is particularly tricky. Equally as challenging is that post-induction, the MICP has only seconds to safely secure the airway before the brain gets angry and shuts everything down. Peri-intubation bradycardia, hypotension, and cardiac arrest often befall patients in metabolic acidosis when advanced airway management becomes the priority. The best treatment for metabolic acidosis is knowing the signs and symptoms and causes. Once identified, immediately focus on dynamic resuscitation in this extremely dangerous metabolic derangement.